Welcome to Raaonline. I am Dr. Balaji Rajaraman, Consultant, Critical Care Services, Apollo Hospitals, Chennai. The topic we are going to discuss now is going to be acute liver failure. A brief overview of the topic. First, we will be seeing why the discussion about the liver failure is important, followed by definition and the categorization and why the categorization carries so much of importance as far as acute liver failure is concerned. Then, we will be seeing how to differentiate between acute liver failure and acute on chronic liver failure. Then what are the varied etiology across various parts of the world as far as acute liver failure is concerned. Of course, clinical features, the pertaining investigations, what are ALF mimics. A lot of conditions can mimic and present like acute liver failure. What are those conditions? How to manage acute liver failure and how to manage acute liver failure related complications, and how will we able to prognosticate a liver failure patients, and finally a sum up of what we have dealt. So, we will go into the topic. The first one is going to be the importance. Why the knowledge about the acute liver failure management and its identification is very important in the day-to-day practice of critical care. The first thing is rarity. Unlike other conditions, the acute liver failure is quite rare in the clinical scenario. If you take up the global census is concerned, it happens in less than 10 cases over a million population globally. So, it is quite rare. Second thing is going to be the severity. Why it is severe? Because it is a complex condition and it not just involves only the liver. There is various organ crosstalk and various organs come into play. So, it is going to be a multi-system or multi-organ involvement. Third one, heterogeneity. If you see the causes of the acute liver failure, the etiology is very varied. So, you do have a varied etiology, and each of these etiology has a very broad spectrum of presentation. So, and in case of any delay in diagnosis the acute liver failure, it incurs a huge morbidity and mortality. And the management strategy of these varied etiology will be different. And finally, some of these cohort of patients who presents with acute failure may eventually need transplant as well. So, because of all these concerns, it is very important to have a good knowledge about the acute liver failure and its management. So, we will start. It is going to be a clinical scenario bar MCQ based discussion. In our clinical scenario, the patient presented to us is going to be a 35-year-old male, no prior comorbid illness. He is IT professional by occupation. It's a very short history, 1 week history of fever which is low grade with yellowish discoloration of sclera. Initially admitted elsewhere, noted to have a deranged LFT along with high ANR, and patient got referred to your center, which is a tertiary care center, because of the worsening neurological status. So, you are examining the patient. So, there is no pallor, he is not cyanosed, there is no clubbing, no generalized lymphadenopathy, there is no pedal edema, he is jaundiced, his JVP is not elevated. Of course, we haven't completed the history completely. When we are going to discuss the ALF mimics and varied etiology of the acute liver failure, we can always revisit the history. What are the important history starting from the presenting complaints to the dietary history? What are the important history we have to ask and elicit while evaluating a patient with acute liver failure? We are going to see in the subsequent slide. Coming to the general examination, why pallor is important? Because acute liver failure tend to have coagulopathy. So, patient had a tendency to bleed. So, coagulopathy may cause bleeding and drop in hemoglobin. So, patient may be pale because of that. That is one reason. What could be the second reason? In some etiology of acute liver failure like Wilson's, patients tend to have something called hemolytic anemia, where there will be the breakdown of your RBCs. So, these are the various reasons why on general examination, whether the patient is looking anemic or not, it is very important to examine. Why cyanosis? Basically, very few liver related conditions can cause cyanosis. One such example is portopulmonary syndrome or portopulmonary hypertension. portopulmonary hypertension is something which happens in a patient with chronic liver disease rather than in a patient with acute liver failure. What about the clubbing? Any of the liver pathology can cause clubbing? Yes, there are two liver pathologies which can cause clubbing. One is your primary biliary cirrhosis, which can cause clubbing, and the second one is your various AV malformations. So, when the liver failure happens, especially the chronic liver disease, there will be a release of numerous because of the portal hypertension, numerous vasodilatory substances will get released. So, in general, the homeostasis will get disturbed by the varied release of your systemic vasoconstrictors and vasodilators, leading to opening up of various small arterial and venous communications. When that happens, patient can have one, high output state, and two, they can have a clubbing. So, coming to the fourth one, which is your generalized lymphadenopathy. Generalized lymphadenopathy, there are certain etiologies which can cause liver failure as well as generalized lymphadenopathy. As far as Indian settings are concerned, one common cause is tuberculosis. Why pedal edema? Liver failure per se can cause ascites, decreased albumin, reduced oncotic pressure, where it can manifest as pedal edema, or else the etiology of the liver failure. For example, if it is caused by a congestive cardiac failure, that particular condition CCF per se will cause pedal edema. So, examination of pedal edema is important in patients with liver failure. Of course, our patient presents with jaundice, which indicates increased in bilirubin level. Coming to the JVP, why elicitation of JVP is important in liver failure patients? Again, one, the etiology of liver failure, especially the chronic liver disease etiologies, can have raised JVPs. Sometimes acute liver failure itself may be precipitated by certain condition like acute RV failure or acute LV failure. In those scenarios, when it is termed as congestive hepatitis. When those scenarios are there, you tend to have a elevated JVP. So, this stresses the importance of the general examination of the patient, which is often overlooked in a critical care setting is concerned. So, after completion of the general examination, we will go to the system specific examination. So, this patient has a GCS of E3, V4, M5 to 6. There is no focal deficit. However, patient is having a flapping kind of tremor. His heart rate is slightly on the higher side. He is tachycardic. His respiratory rate is within normal limits. SpO2, he is saturating decent of 96 on room air. Blood pressure, you can watch the wide pulse pressure. Acute liver failure is one of the conditions which presents with wide pulse pressure because of the SIRS it induces. The cardiac examination per se is not significant. S1, S2, first and second heart sounds are there. There are no murmurs. And in respiratory system examination, there are no added sounds. And in per-abdomen, which is often present in patient with acute liver failure, is the hepatitis. So, when there is a hepatitis, you will have a pain over the inflamed site. In this condition, in the liver, it will get manifested as a right hypochondrial tenderness. So, this patient, you have ordered some investigations. You can see yourself that the total count is slightly on the higher side, and there is a thrombocytopenia is there. There is mildly dearranged KFT levels. There is a slight increase in urea and slight increase in creatinine. There is mild hypokalemia. And the liver function test. So, basically, he has a very high bilirubin levels and very high enzyme levels, and serum albumin is okay, it's well within normal limits, probably it's in the lower range of normal limit. INR is also elevated, serum glucose is decreased, and serum lactate is in the higher level. So, this is the brief clinical information we have got as far as this patient is concerned. So, we have got a history, we know what's the findings in the general examination, we do have some relevant lab investigation. Let's move on to the first multiple choice question about this patient. So, pick up the wrong statements regarding acute liver failure. The criteria includes, option A is, the criteria includes dearrangement of LFT manifested by elevated enzyme levels and abnormal USG findings. Option B is nomenclature and categorization is uniform across all parts of the world. Option C is subacute category has favorable prognosis as recovery is more likely in these scenarios. And final option is hyperacute failure carries high risk of cerebral edema. Fine. We'll go to the discussion part. When we discuss the relevant clinical informations and the theory, then we'll come back to the MCQ. Coming to the definition. As far as the definition of the acute liver failure is concerned, what you should understand is basically the definition is very varied. Okay, and it starts as early as 1930 when in Germany they labeled it as something called acute yellow fever with dystrophy. That is what it got labeled in initially as early as 1930. In those times, especially during the World War II, there is numerous epidemic outbreak of hepatitis, be it to poor sanitation, be it to the fecal-oral contamination. There is a large number of outbreak of hepatitis. So that time when Mallory and Lucky interpreted those subset of patients, they termed it as one as acute yellow fever dystrophy, two as fulminant epidemic hepatitis. So these are the various terminologies given for acute liver failure at various point of times. But what is more important is, if you open the textbook and if you see data regarding the acute liver failure, you will have close to more than 50 odd definitions for the definition of liver failure, what exactly to look for and what time period to look for. So should we remember all these things? The answer is no. So basically what the relevant information for us as a postgraduates is, one, what the basic information we need is, one, we will have a dearrangement. The severe acute liver injury means we will have a dearrangement of LFTs and the presents as a dearranged LFTs, and there should be a prerequisite of, this is a mandatory criteria, presence of hepatic encephalopathy is a mandatory criteria and the presence of coagulopathy is a mandatory criteria. So here the synthetic function of the liver, which is liver secretes clotting factors. When the synthetic function of the liver decreases, then obviously the INR is going to shoot up. So the synthetic function of the liver is decreased. And the event is acute. We are discussing about acute liver failure. So the time duration is 26 weeks. And we have to make sure that there is no pre-existing liver diseases. So what are the prerequisites to diagnose a patient with acute liver failure? One, the event should be acute, which is less than 26 weeks. Two, the synthetic function of the liver should be less, as manifested by INR of more than 1.5. Three, the metabolic function of the liver has affected. The ability of the liver to metabolize ammonia is poor, as manifested by hepatic encephalopathy. And all these events should happen in a patient with no pre-existing liver failure. So these are the prerequisites to diagnose the acute liver failure. Why so much of attention is given for categorization? So basically these are the various categorizing schemes which is available globally. The Bernau system, O-Grady system, especially the O-Grady system, from the data comes from England, where the data from the King's College has been put into place to divide the acute liver failure into less than 1 week, less than 1 month or more than 1 month. Do we need to remember all these categorization schemes? Yes, we have defined acute liver failure, but why we should remember all these categorization schemes, we will see. So these are the various definitions available. So we need not to by heart it, nor we need not to mug it up. So we'll see why the categorization is important. First thing. So we will go by mostly by the O-Grady's definition, that is the King's College criteria of hyperacute liver failure, where it is defined by, this is less than 7 days, this is 7 to 28 days, and the subacute liver failure as manifested by more than 28 days. So in case if you want to remember, the simplest thing will be, so this will be less than 1 week, so this will be less than 1 month, and this is going to be more than 1 month, and we do have a lower limit of 26 weeks. Why this categorization is important? As you can see, the risk of cerebral edema and the chances of recovery from the liver failure depends on what kind of subcategory it is. For example, in case of hyperacute liver failure, patient has a very high risk of developing a cerebral edema. Whereas in case of subacute acute liver failure, where it happens, the time interval between the onset of jaundice to the encephalopathy. So this is the most important criteria we will look into. That by time interval we mean the gap between the onset of jaundice and the onset of encephalopathy. If the interval between the onset of jaundice and encephalopathy is less than 1 week, it is termed as hyperacute liver failure, where it carries a very high risk of cerebral edema. Whereas if the time interval between the onset of jaundice and onset of encephalopathy is more than 28 days, then it is termed as subacute liver failure and the risk of cerebral edema is comparatively less. So, the subcategorization of your acute liver failure can predict the development of your cerebral edema. So, the hyperacute category carries a very high risk of developing a cerebral edema, whereas the subacute liver failure, the tendency to develop a cerebral edema is not as high as compared to the hyperacute liver failure. And coming to the chances of recovery also, the hyperacute has a higher chances of recovery, whereas the subacute liver failure carries relatively poor prognosis. So, this hyperacute basically has higher risk of complications, whereas if you are able to tide over the initial phase and if you are able to manage the initial few tough days in ICU, then probably the chances of recovery is good. So, this is why the subcategorization of acute liver failure is very important. And you can clearly see we have placed a disclaimer here. Why is it so? Because it is not always a rule of thumb, because the etiology of each of these things, for example, the same hepatitis can cause either of these things. It can present as a subacute as well as present as an acute. So, these are all it's not a rule of thumb. There can be always exceptions as far as the risk of cerebral edema and chances of recovery is concerned. When you see the real lifetime examples, hyperacute liver failure, commonest example is paracetamol poisoning, ischemic hepatitis, hepatitis A and E viruses. If you see the subacute liver failure, then the most common example is ATT, causing drug-induced liver injury. And the Wilson's autoimmune hepatitis can cause acute ALF. And you can see that the hepatotropic viruses, which is your hepatitis viruses, falls into both acute hepatitis HIV viruses as well as hepatitis B viruses as well. So, basically what we have to understand is, one, yes, for the diagnosis of acute liver failure, you should have a period of less than 26 weeks. Patient should not have any pre-existing liver diseases. 3, you should have a abnormal in synthetic function as manifested by the elevated INR. You should have a abnormal metabolic function of the liver as manifested by improper metabolization of ammonia leading on to hepatic encephalopathy. If these events happen, it is acute liver failure. And after that, we are subcategorizing this acute liver failure into 3 groups, as less than 1 week is hyperacute, less than 1 month is acute, and more than 1 month or up to 26 weeks is your subacute liver failure, because the risk of cerebral edema and the chances of recovery varies between these groups. So, with this background knowledge, let us pick up the wrong statements. So, we are going to pick up the wrong statements. There can be more than one statements here. So, the criteria includes derangement of liver function test, elevated enzymes and USG abdomen findings. No. So, the criteria predominantly, as we saw, it includes just 4. What are the 4? It will have INR, it will have a hepatic encephalopathy, it will have no pre-existing liver diseases, and finally, what will have duration of less than 26 weeks. This is what the criteria of ALF has. So, it doesn't include USG abdomen, nor it doesn't include any elevated liver enzymes. Nomenclature and categorization is uniform. No, that is a problem with the definition of the acute liver failure. You will have a varied nomenclature. What gets classified as a subacute in one category may get classified as a fulminant in other category. So, the nomenclature and categorization is not uniform. So, this statement is wrong, this statement is wrong. Subacute category has more favorable prognosis as recovery is more likely in these scenarios. As we saw in the last table, the subacute category has a less favorable prognosis. Even though it is subacute, the chances of recovery is less compared to the other two variants, which is your hyperacute and acute. Finally, hyperacute liver failure carries high risk of cerebral edema. This is the only true statement, because as you see, the hyperacute variant carries the highest risk of cerebral edema, followed by the acute variant, followed by the subacute variant, which we saw in the previous slides. So, the wrong statements are option A is wrong, option B is wrong, option C is wrong, and option D is the only right statement in the first MCQ. Let us go to the second MCQ. So, the same scenario has continued. Basically, to evaluate the etiology, we have sent a tropical panel. So, dengue, malaria, scrub typhus, leptospirosis, those were negative. And basically, they have done a serum ceruloplasmin to rule out Wilson's, which falls within the normal limits. You can see that there is some hepatomegaly in the USG abdomen. There is a minimal pericholecystic fluid and there is a minimal reactive pleural effusion, because always acute liver failure will have some degree of hepatitis. It is very natural that you will be developing a reactionary edema in the site of inflammation and sites contiguous to the inflammation. So, you will have a reactionary edema in the liver as well as in the pleural space, and no evidence of cirrhosis is in the USG abdomen, and workup for serology of IgM HAV is positive. So, what is our syndromic diagnosis? So, you will have acute liver failure, acute on chronic liver failure, decompensated liver disease. Answer is no. So, basically what we are trying to interpret is whether it is acute liver failure or acute on chronic liver failure versus decompensated liver disease. Why it is important? So, basically here we are going to differentiate between the acute liver failure and acute on chronic liver failure. Let us take two scenarios. So, you do have two USG abdomens. So, you can see the liver, this is the liver and this is the kidney. And in case 1, here you can see that the liver parenchyma, even though it is slightly hyperechoic with something called starry sky appearance, which is the appearance they used to describe the acute hepatitis. And here you can see that there is a lot of nodularity and there is a ascites and there is a shrunken liver. You can see the size of the liver which is shrunken, which depicts a cirrhosis. So, whenever there is an insult which happens in a normal liver, usually it presents with the manifestation of jaundice, coagulopathy and encephalopathy, which you will label it as acute liver failure, which is the topic for our discussion. Whereas in case, if any insults happen in already diseased liver, then the myriad of manifestations can be varied. Most commonly, it can present as ascites and encephalopathy, but it is not just that. So, most of the part of ACLF can have any organ dysfunction. This organ includes any part of the body. So, patient can present with shock, patient can present with AKI, patient can present with encephalopathy. So, any organ or organ system can be involved. So, this will be termed as acute on chronic liver failure. So, the basic understanding is, if you want to label a patient to have acute liver failure, there shouldn't be any pre-existing liver diseases. Whereas, if you have any evidence of this like ascites, cirrhosis, nodular liver, then most probably we are dealing a patient with acute on chronic liver failure. Then the question comes, why this differentiation is important? Let it be acute liver failure, let it be acute on chronic liver failure. Why I have to sit and differentiate between these two etiologies? So, there are very few exceptions which present. Even though if patient have a pre-existing liver condition, you can still treat the patient as a case of acute liver failure. There are very few exceptions, and these are all acute phase in autoimmune hepatitis or hepatitis B viruses, patients with Wilson's disease who presents acutely, and patients with hepatic venous outflow tract obstruction or Budd-Chiari syndrome, and patients with fatty liver or acute fatty liver of pregnancy. In all these scenarios, even though if the patient have some, for example, if a patient has a carrier of hepatitis B viruses with no evidence of any cirrhosis, if that patient presents with the triad of your dearranged LFT, your INR is elevated, encephalopathy, you can still treat that patient as acute liver failure rather than a acute on chronic liver failure. So these are the very few exceptions to the definition what we saw. Now, coming to the importance of why we have to delineate between the acute liver failure and acute on chronic liver failure. 1. The patient, the presentation, the management, everything differs between patients with acute liver failure and acute on chronic liver failure. For example, these acute liver failure patients, tend to will be relatively younger in age group, whereas acute on chronic liver failure will be slightly older. And technically, these don't have any comorbids, at least liver related comorbids. This comorbids may not be there in acute liver failure, where patients can have some comorbidity in acute on chronic liver failure. Third, cirrhosis should be absent, portal hypertension should be absent in acute liver failure, whereas in acute on chronic liver failure, these two entities can be still present, should be present. Serum ammonia levels are very high in acute liver failure, whereas ammonia is not a marker of encephalopathy in acute on chronic liver failure. Tendency of a patient to develop cerebral edema is very high in acute liver failure, whereas it is not in acute on chronic liver failure. Same goes with intracranial hypertension. Yes, both the conditions can cause renal dysfunction. Both acute liver failure as well as acute on chronic liver failure can cause renal dysfunction. Sarcopenia is more of a finding with chronic liver failure, whereas coagulopathy can happen in both acute and chronic liver failure. So, you do have a myriad of manifestations, as you can see. The comorbidity is uncommon, whereas it is common in acute on chronic liver failure. And you don't have a cirrhosis in acute liver failure, and you do have a cirrhosis in chronic liver failure. Portal hypertension is not common, portal hypertension is common. Serum ammonia is very high. It can be upper limit of the normal also in acute on chronic liver failure. So, high tendency to cause cerebral edema, whereas it is not. So, renal dysfunction is common, coagulopathy is common in both the entities. So, presentation and risk factors itself is different between acute liver failure and acute on chronic liver failure. That is why you have to differentiate both the entities. It is not just the presentation, it is a management as well. You can see that, for example, therapeutic plasma exchange, which has some role in acute liver failure, doesn't have any role, at least not a clear role in acute on chronic liver failure. So, this categorization, this differentiation influences your management as well. For example, the liver support therapy has no role in either of these things. These three things, which is your lactulose, rifaximin and LOLA, don't have any role in acute liver failure, whereas all these things are used invariably in acute on chronic liver failure. So, you have to diagnose ALF. You cannot stop there. You have to diagnose ALF based on 4 things. That is your altered liver function test. There should be jaundice. There should be elevated INR, there should be hepatic encephalopathy, and it should be presenting within less than 26 weeks. You can't stop there. Then you have to differentiate. So, after diagnosing ALF, further you have to subcategorize ALF into 3, which is your hyperacute, acute and subacute as less than 1 week, less than 1 month and more than 1 month and less than 26 weeks. And you have to do a double check to make sure that this is not ACLF. So, because the presentation and management is different between acute liver failure and acute on chronic liver failure. So, coming back to our MCQ. So, if you see what is the important Q in this MCQ. So, basically you do have done a USG abdomen, and this USG abdomen neither has cirrhosis nor it doesn't have any nodularity, even though a small amount of free fluid is there in the pericholecystic area, in the subhepatic region and the reactive effusion, all these things are still there. We have already discussed that any inflammation is accompanied by reactive fluid collection. So, basically we do have a dearrangement in liver function test with elevated INR with hepatic encephalopathy in a patient who doesn't have a earlier liver related comorbid condition. So, we are dealing with something called acute liver failure, which is the answer for your MCQs. Coming to the etiology. What could be the etiology of the acute liver failure? So there is n number of etiology which can cause acute liver failure. It is humanly impossible to remember all those things. But as a medical postgraduates, what we can understand is we can go by the alphabetical order. So the etiology, first thing you want to understand is, despite evaluation, despite complete evaluation, you may not be able to diagnose the etiology of all ALF. Okay. So papers do carry something called indeterminate cause for those subset of patients, and in some part of the world this indeterminate cause is the major cause of ALF. So despite doing a thorough investigation and etiological evaluation, you may not be able to find a cause for a acute liver failure, and those subsets should be deemed as indeterminate. And second point you should understand is, if you go to various parts of the world, the etiology of ALF differs. So it has a geographical heterogeneity, because what is the most common cause of ALF in the Western world? For example, if it is paracetamol, in the Indian subcontinent, the paracetamol is not the common cause of ALF. It is either indeterminate in some studies or hepatitis in some other studies, or drug induced in other studies. So there is a huge geographical heterogeneity as far as ALF is concerned. So we can remember based on the alphabetical order: A, paracetamol, which is most common in the Western world, consumption of toxic mushrooms like amanitophiloids; hepatitis A, and autoimmune hepatitis. B, you can have a hepatitis B virus or Budd-Chiari venous obstruction or Budd-Chiari syndrome. C, you can have a hepatitis C virus, CMV, or Wilson's disease. D for drug. Again, you can have the most common three sets of drugs: one, which is the paracetamol; two, anti-tuberculous medications; three, anticonvulsants. So ATT and anticonvulsants, and of course paracetamol, these are the most common drugs which can cause acute liver failure. E for Epstein-Barr virus, F fatty liver of pregnancy, H for hypoperfusion, which is shock liver, which happens after a hypoxic arrest or any chances of cardiac arrest or sometimes severe cardiogenic shock. So all these things can cause acute liver failure. And finally, the other infective causes apart from your hepatotropic viruses like HSV virus, VZV, and finally comes your indeterminate cause. What is the indeterminate cause? Which means that despite the appropriate etiological evaluation, you are not able to pinpoint the etiology of your acute liver failure. So as far as etiology is concerned, yes, you can have a mnemonic with A, B, C, D, E, F, H, I, and despite this, you have to understand two things. One, despite evaluation, a huge chunk of patient you may not be able to identify any cause which is indeterminate, and your etiology will vary in various parts of the globe. So this is a Western data. As you can see, the paracetamol is the cause of your acute liver failure, followed by your indeterminate cause. And this is an article from the New England Journal of Medicine. As you can see that in India, this is the data in 2013. In India, the huge chunk is caused by hepatitis E virus at that point of time, and the incidence of paracetamol related acute liver failure is almost close to 0%. And you can see here that the orange one is unknown. This unknown forms a chunk on most part of the world. So ALF, yes, it's better to have a diagnostic algorithm, but please do mind that despite appropriate evaluation, close to 30% of the patient, you may not be able to identify any trigger for the acute liver failure. So if that is the case, what are the workup we need to do in a patient with acute liver failure? These workups you can divide it into three types. The first one is a diagnostic workup. Why acute liver failure has happened? So, and you should be able to diagnose and pinpoint to say that this is acute liver failure. So those are the diagnostic workups. Two, what has triggered my acute liver failure? That is my etiological diagnosis. So workup towards the etiology. Three is towards the complications. What are the complications my patient is having because of the acute liver failure? So the diagnostic workup, obviously it includes LFT, and you will have a synthetic function which is your INR, your USG abdomen, and sometimes your transjugular liver biopsy, etc. And here the bone marrow has come with a disclaimer because in some time we are going to discuss something called ALF mimics, where you will find a role to differentiate what is the etiology of this acute liver failure. You will see about tropical profile and bone marrow in those slides. Second one, coming to the etiology, so we can run a viral hepatitis panel, we can run an autoimmune profile, you can see the other hepatotropic viruses apart from hepatitis, which is your HSV, VZV and CMV, and the copper metabolic abnormality, which is your Wilson's disease. And the same ophthalmic examination is to diagnose the KF rings in your Wilson's disease. Doppler USG to pick up hepatic venous outflow tract obstruction or Budd-Chiari syndrome, and of course serum paracetamol levels. In case the acute liver failure is caused by any cardiac cause, be it hypoxic hepatitis because of the congestion or hyperperfusion, you need to do a echocardiography. Coming to the complications, if you want to diagnose hepatic encephalopathy, serum ammonia levels you may need, and acute liver failure is most common cause of hypoglycemia. In case if there is a bleed, probably you may have to do a group typing and cross matching for transfusion, and CT brain to diagnose cerebral edema. And there is a myriad of electrolyte abnormalities which can happen with ALF, which we are going to see in the subsequent slides. So basically, the take home message is any patients with ALF, they need a lot of investigations, and your investigations should be targeting three things. One, to diagnose ALF itself, first thing. Two, what is causing my ALF, that is identification of etiology is the second thing. Three, whether it is just ALF or my ALF is producing any complications, to diagnose this. For the diagnosis of complication is a third set of investigations. As we discussed earlier in our second slide, we did have a very short history. So, is the short history is enough as far as ALF patients is concerned? The answer is no. Now, we are having some background knowledge about the etiology and diagnosis and categorization of acute liver failure. So, now we are going back and see what are the history you have to take while eliciting, while dealing a patient with acute liver failure. The first thing is the duration between jaundice and encephalopathy. In our patient, it is 1 week. So, why this is important? This part is important because based on this, you can further subclassify into hyperacute, acute and subacute, which will have its own prognostic implications. So, since they carry a prognostic implications, you should know the interval between, the time interval between the onset of jaundice to the encephalopathy. This time interval between the onset of jaundice and encephalopathy is very important. What is the other one? History of cardiorespiratory illness. It can be pertaining to congestion, it can be pertaining to hypotension, hypoperfusion. So, what are the history you can take? Dyspnea, orthopnea, chest pain, history of palpitations or arrhythmia, history of pedal edema, because both forward failure, which is your LV failure, and backward failure, which is either a RV failure or congestion, both of these things causes abnormal liver function test and causes ALF. History of abdominal pain and other GI symptoms. This is the most common presentation in a patients with hepatitis viruses. So, they will have a low grade abdominal pain, especially in the right hypochondrium, like our patient, and other GI symptoms like nausea and vomiting do happen in patients with acute liver failure. Sometimes some of these patients can complicated by pancreatitis. So, the history of abdominal pain is not only helps in the diagnosis of your liver failure, and it can help in finding whether this patient is out of proportion. Abdominal pain never happens in acute liver failure, but whereas the secondary complication like pancreatitis can have a out of proportion abdominal pain. Women in reproductive age group. Why the history is important? The last menstrual period, because we do have one entity called acute fatty liver of pregnancy, which do happen in a pregnant woman. So, dietary history. Why dietary history is important? Because there is a cultural intake of mushrooms, which is your amanitida phylloides, can cause acute liver failure. So, any recent intake of wild mushrooms should be elicited. Medication history. This is a very important, as we have seen that DILI is one of the most important cause of acute liver failure in India is concerned. So, pertaining to DILI, you should have history regarding 4 group of drugs. Of course, your painkillers, which is your paracetamol, and second, your ATT medications, and third your anticonvulsant medications, and fourth is the alternative medicines or your herbal supplements. The best thing to do is to ask the patient's relative to get the prescriptions of whatever drugs he is on, but these are the 4 common subgroup of drugs which can cause acute liver failure as far as Indian population is concerned. Personal history. Why personal history is important? Substance abuse. So it is not just alcohol. Some of these toxic substances like MDMA, amphetamine and cocaine can cause hyperacute liver failure. So the personal history is very important. Finally, family history. Why we are eliciting a family history? We do have certain diseases which can run in families, and especially the autoimmune hepatitis, you can find any relevant history in any of your family members. So the history taking forms a crucial part, and why we have dealt about the history taking after the initial few slides is the thought process being you have a basic knowledge of what is ALF, what are the subcategory, and how to differentiate between ACF and ALF, what are the differences involved in management. And etiology. So now we know what are the history related points which has to be given importance while examining a patient with acute liver failure.